Thank you, Ajit. Great meeting you across the internet, and thanks to both Anil and Dr. Rajshekar for inviting me for this talk. I think obviously this talk is, or this whole program is dedicated to the technical aspects of how to do a chip intervention. And most of the time, support in chip is because of the anatomic considerations of the lesion, and I think you're going to have a live case demonstration shortly after this. But in my talk, I'm going to restrict myself to the cardiogenic shock in the setting of an acute myocardial infarction and adjunctive revascularization. So when you take a look at the modern cardiac ICU, and this is data from both ours as well as 30 units across the CCUs in the United States, about 1 in 5 patients who come into our CCU today has cardiogenic shock. In the kind of shock, clearly 2/3 of them are cardiogenic. And when you take a look at cardiogenic shock, it's actually quite surprising that now only 1/3 of our shock is acute myocardial infarction related. A lot of our other shock is in the setting of heart failure, electrical storm, and other conditions. And obviously in this talk, given the revascularization, I'm going to talk a lot about AMI-related cardiogenic shock. When we look at shock, the only real data that we have for us to move the needle has been our efforts in the shock trial dating way back to the 1990s. It's important to know that in the shock trial, we randomized patients to an early revascularization strategy shortly after anatomical definition. And the revascularization strategy could have consisted either of emergent PCI, and this was an era where all we had was balloon angioplasty, so there was no stenting in a majority of these patients, or patients went for emergent bypass surgery. On the conservative arm, the patients had an intra-aortic balloon pump, most got fibrinolysis, and you can see that in this relatively small trial, at the end of 1 year, we saved 13 lives per 100 patients treated. And as a result of that, it became a class 1 indication in cardiogenic shock. And so the whole goal in the setting of an acute MI cardiogenic shock is to revascularize the patient. Now, despite revascularizing the patient, 2 things can happen. One is that you revascularize the patient, but there's enough peripheral end organ injury that the patient does not recover. And 2 is the fact that you may revascularize the patient, but you don't salvage enough myocardium to actually gain hemodynamic stability, and so shock continues to persist. And for that reason, the availability of current temporary reliable mechanical support has really transformed the landscape in that it has given us an opportunity that while we revascularize this patient, we can support the circulation. And we can do that with a number of technologies that are well known to the audience. Clearly, we could use an ECMO for biventricular support, as was outlined in the previous talk. In the setting of an emergency, this is almost always pump-fem-fem cannulation in the periphery. We can use a tandem heart with or without an oxygenator for support. And obviously, with a tandem heart, you need the expertise to go across the interatrial septum into the left atrium in an emergency. Our workhorse has been the impeller, and clearly the impeller comes with different devices and different degrees of support. And so that's important to know. And finally, we can use devices like the CentriMag in this situation to support the circulation. We also have multiple ways to support the right side of the heart. And so cardiologists, when you have a hemodynamically unstable patient with refractory shock, we are able to choose a device that can provide different degrees of unloading based on the device that we choose. And we can also show ventricular specific support so that if we needed isolated left ventricular support, we could use something like an Impeller 5.5. On the other hand, if we needed right ventricular support, we could go with a Protect Duo. Or if we needed biventricular support, we could go with an ECMO. So all of these strategies are now readily available to the cardiologist by the bedside. And because of that, And because of the mortality rate that continues to persist in the setting of shock with simple revascularization, we've actually changed our way of looking at our treatment paradigm for shock in the acute MI setting. Clearly, on initial presentation, there is a group of patients who, although challenging, we readily recognize that care is going to be futile. This may be someone who's had a prolonged out-of-hospital cardiac arrest, who's showing signs of an anoxic encephalopathy. This may be an elderly patient who's got multiple strokes and on hemodialysis. I think we all recognize that really revascularizing patients in this scenario is not commensurate with a reasonable lifespan or a quality of life. And I think to proceed with further support in that situation is inappropriate. On the other hand, at 3 o'clock in the morning, faced with a middle-aged person who comes in with a large myocardial infarction, I think we would all give the benefit of the doubt and bridge the patient along with adjunctive revascularization in some fashion. And so when we do bridge the patient, either with an ECMO or with an impeller, I think we have three goals in mind. One clearly is that after completion of revascularization, the stunned myocardium returns and we salvage enough myocardium to maintain hemodynamic stability. Those patients are able to be weaned off. Two, there are patients who continue to be in refractory shock who are poor candidates for advanced mechanical support, and in those patients we are able to withdraw support in a controlled fashion. And finally, depending on the center you're in, if you have advanced options in the ideal patient, we could certainly consider whether a left ventricular durable assist device or a transplant may be appropriate. And these will be in a cherry-picked handful of patients who actually fulfill that goal. And so when you put these things together, this would be an ideal situation where, you know, a 50-year-old person comes in with an acute myocardial infarction. He's got an occlusion of the proximal LAD with TIMI zero flow. This patient has been resuscitated on the field and intubated. You take them to the cath lab and you very nicely open up the coronary artery. I'm not sure if that is showing because of the speed of the internet, but we get a very nice result in the LAD. Following that, the patient remains in refractory shock, and as you can see on the left, the ventricle is completely hypokinetic, not just in the infarct zone, but in the non-infarct zone, just because the patient has had prolonged cardiac arrest. And in this person, despite our revascularization, liver injury and kidney injury and brain injury are almost certain if we were to continue with simple vasopressor support. On the other hand, putting this patient on ECMO support gives us the unique opportunity that, given the fact that the patient presented early, we were able to salvage and open up the LAD with great flow, as maintaining the microcirculation. You can see normal contractility in the infarct-related zone, as well as a non-infarct-related zone in this cherry-pick case. And this would be our ideal construct for why we put mechanical support in these situations, is that we all have cases like this that we are certainly very proud of. But that being said, I think we really need to look at the overall evidence to say that before we embark on these strategies of highly expensive devices which have a huge vascular profile, huge risk of complications, what is the current data to support adjunctive revascularization in this setting? And obviously shown here is a paucity of data that without any proof that using routine, and I say routine as a term, routine strategy of support in the setting of shock has certainly not been associated with improved mortality. Now, the absence of a clinical trial does not mean absence of evidence, but certainly from a guideline standpoint, I think it's a little harsh that the intra-aortic balloon pump is given a class 3 indication by the ESC, but that is certainly the case if you were to consider the use of an IABP for circulatory support alone. And that data really comes from the IABP2 shock trial done by the Germans. 600 patients with cardiogenic shock from acute myocardial infarction, all of whom get PCI. placement of an intra-aortic balloon pump for refractory shock adjunctive to the PCI. And you can see in this clinical trial, the role of an IABP was negligible in terms of improving outcome. And when you actually look at the data out at 6 years, there is really no group of patients in whom there is any signal of benefit in the IABP shock trial. Now, there are a number of issues with the IABP shock trial that I think need to be considered. It's a pretty unique population. 30 to 40% of the people in the IABP2 shock trial were non-ST elevation acute coronary syndrome, which is just not consistent with clinical practice. A large proportion, more than 50%, had an out-of-hospital cardiac arrest. And so these are very, very different and unique patients. But I do think that what the IABP shock trial tells us is that if someone is in hemodynamic instability and hyperperfused following PCI, the hemodynamic support then presented to the circulation by an IABP is negligible and is unlikely to impact on long-term survival. That being said, the data with ECMO as well as Impeller are equally sparse. This is data from the ECMO CS trial, just published association from Czechoslovakia this past November. They took a very small trial showing you the challenges of doing these kinds of trials in this kind of a situation. They took 80 patients in this study. About 50% were in the context of an acute MI. Most of these patients were in refractory shock. They were randomized to having ECMO placed versus standard therapy. And you can see that in this trial, the use of an ECMO. Being said, at the bedside, clearly, given the nature of challenges faced by the clinician, the use of an impeller in the United States has increased dramatically over time, as shown on the left. But even despite this increase, what we do see when we do a propensity-based analysis, which still is associated with a whole lot of confounding, we can see that the use of impeller in these large registries are actually associated with increased rates of death and increased major bleeding with no signs of benefit. We clearly don't think there is a huge amount of harm here. There's obviously confounding in registries that things like propensity matching don't adjust for. But that being said, for a costly device that's a huge investment that has significant complications, the fact that we don't see an elegant signal of benefit suggests that being cavalier with these devices is not the way to go in this current era, given the advice provided. And that's further heightened by this. These are 30 sites across the United States in our C3TH. And you can see that in a large proportion of these CICUs, the bulk of the support devices still tends to be an intra-aortic balloon pump in the United States. And you can also see a huge variability in the use of advanced support devices from one unit to another, suggesting that even with
Venu, we've just lost contact with you. I'm not sure whether
use in this setting. Sorry, Ajit?
Yeah, Venu, I can hear you. I think maybe you can keep your video off and just speak. That would help,
my video is off. Yeah.
Okay. Now the signal is better. Yeah.
I'm so sorry for that. And so these are ongoing large randomized clinical trials with the impeller device that are forthcoming in the next few years, the results of which will certainly inform us as to what device we should use in what specific situation. So how do we then move the needle to improve outcomes with cardiogenic shock? The goals of emergency circulatory support, like I mentioned, is one, to restore adequate end organ perfusion. It's certainly to support the injured ventricle, and finally to allow a safe bridge to recovery, transplant, or a permanent device. As we say, to save the patient, save the heart, and save a life. And so to do that with these expensive devices, we have made a decision to form shock teams across the United States to be a little more responsible and judicious about using these devices at the right time in the right patient with the right exit strategy. And so shown here would be the components of a shock team at the Cleveland Clinic. This is a 24/7, 365 hotline, very similar to our STEMI activation. When we activate for a shock call, we immediately have a cardiothoracic surgeon with heart failure expertise, an interventional cardiologist, a critical care cardiologist, and a heart failure cardiologist come online, and we make a decision. One, is transfer appropriate? Two, is adjunctive revascularization with what kind of support device? Is there an exit strategy? What should that exit strategy be? And all these are decisions that are made while the patient is getting on table and not made emotionally at the end of a case. And so what we would normally do in a situation like this is that someone in circulatory collapse would almost always get a VA ECMO along with a reperfusion sheet with something like an intra-aortic balloon pump that's decompressing the left ventricle. That may then go on to get axillary impeller if it becomes isolated LV support. And then you can see the various parameters that we could use to wean patients off an intra-aortic balloon pump or off supportive devices in the days and weeks after revascularization. Is there any suggestion of benefit that this kind of a team actually benefits in terms of patient outcomes? This is the initial paper from the Inova Fairfax group published in JACC in 2019. You can see dramatic improvements in mortality for both acute MI and acute non-acute MI cardiogenic shock with the use of a shock team. But I remain highly skeptical of the data, as the amount of improvement clearly shows bias and confounding, and we would not expect such dramatic changes just from adopting a shock team approach. This data, which was earlier shown, is more compelling. This is our data from the C3TN network. We have about 30 CCUs in the United States that register in this network, and about half of us have a shock team and half of us do not. You can see that the patients with shock, both in the main hospital with a shock team and in other hospitals without, are very, very similar in terms of their hemodynamic profile. But the use of a shock team led to more use of PA catheterization, more advanced MCS use than routine MCS use, with an associated decline in mortality rate, which may be a reflection of decision-making, timeliness of decision-making, rather than any one of these individual interventions that Ajit outlined in the last talk. And I'm fully in agreement with him on his interpretation of this data. But I do think that having this kind of a shock team allows you to deliver consistent care to very vulnerable patients who have a very high mortality rate. And so I will conclude by saying that MCS devices have changed the landscape of shock management. Robust evidence for benefit with MCS remains lacking. There is creation of a shock team does facilitate complex time-sensitive care in a consistent fashion. And the initial data with shock teams suggest improved outcome, but the mechanism by which it does so remains uncertain and is likely due to decision-making and timeliness of intervention rather than any individual therapy. Thank you very much for your attention, and I'll stop sharing my screen with that.
Thank you, Venu, for a very clear message. Can I ask my colleagues to have any questions for Venu?
Hi, Venu, it's Arun Kumar here. Can you hear me?
Yeah, I can hear you.
Yeah. So you were talking about the injured ventricle. When you place somebody with cardiogenic shock on VA ECMO, from your experience, will you say that there should always be some sort of LV venting in the first instance, or do you wait and watch before placing a venting, either IABP or impeller?
We always routinely vent when we go on with ECMO. Obviously, we think that mechanistically the ECMO is a terrible device to support the ventricle, just given the fact that everything that we want, we're increasing work of the ventricle, we're having risk of vascular access, we have risk with cerebral perfusion. But in the setting of circulatory shock, it's the most easily available device. And so whenever we use it, we almost always use a mechanical form of decompression, which is almost always an intra-aortic balloon pump or an impeller device. Rarely, in the setting of shock due to congestive heart failure, non-ischemic, something like dobutamine or something like that to decompress the left ventricle could be considered. But we almost always use a decompressive device because of the complications in the lung.
Right. So nice talk, Dr. Menon. In the IABP shock trial, 84% of the patients, they had the balloon once they developed the shock. And that makes huge difference when you actually introduce the MCS. If you introduce before actually touching the coronary, even with the wire or the guiding, that's why the new concept of D2E is coming. Now my question to you, how do you define the success? You define success of MCS by cardiovascular death or all-cause death? If you put MCS, people can die due to cardiovascular cause, can be due to local complications, losing limb, can be due to acute renal failure, could be due to sepsis. And cardiovascular death in our country is a subjective, in the death certificate, right? Every death is a cardiovascular death. We actually do not.
Yeah.
So how do you define your success?
I don't think it matters to the patient if they're dead, no matter why they die. So the only thing that matters is all-cause mortality. And so we think that opening up a vessel and the patient dying of a non-cardiovascular cause like anoxic encephalopathy does not make us, then it's not a good approach. So I think all-cause mortality is what really counts in this situation. And so that's what makes decision-making so difficult in an emergent situation.
I can go ahead. Dr. Menon, thanks for an eye-opening talk on mechanical circulatory support. But both the speakers were telling the data, since so many years, if you see whether it is IABP, in the shock trial 1 and 2, the impeller consistently has shown that impeller does not improve the mortality and other parameters related to the outcomes. So, but in the other slide, you showed that the impeller use in US is consistently going up. So how do you explain this? No, because you only...
Yeah, I do think that there are two things, and that increases the responsibility for us as cardiologists. The impeller is a costly device. When I place an impeller, I get paid for it. The company is very happy with the impeller because the company gets paid for it. And the patient wants the best chances at a positive outcome. So there is no driver here to say, let us limit the use of impeller. You're clearly in trouble and the device can clearly support you. And there is no doubt that the device does what it is supposed to do. The impeller provides great support, but if someone comes in late after a myocardial infarction and you don't salvage anything unless you have an exit strategy. The impeller is not a therapeutic device. The impeller is a supportive device. And I think what we are facing here is the lack of adequate exit strategies. Even when I show you durable left ventricular assist device and transplant, the pressure on getting great outcomes with LVAD and transplant is so high that very selective patients are chosen for LVAD and transplant with an acute myocardial infarction. And so this is a very challenging time. And I think we have to be very responsible, especially in a country like India, where a cost and everything is so dramatic, that we don't use these devices just because we can. I think on the other hand, if you have someone with a postpartum cardiomyopathy, these devices are fantastic. They support the circulation, acute myocarditis, all the people we could never save, we put them on support. 2 days later, they have normal ventricles, they have great lives ahead. Those are easy decisions. With acute myocardial infarction, out of hospital cardiac arrest, I see this as a lot of questions still to be answered.
Thank you.
So my question is, sir, in typical case of cardiogenic shock, the patient goes on a VA ECMO peripheral. You try to attain full flows, or you keep a partial flow with heart ejecting?
No, we try to. So obviously, whenever we put ECMO, we'll always have a right radial artery line. We'll always have a swan. So we'll know what pulsatility is both on the arterial side as well as on the pulmonary side. We are very careful because remember, you have a mixing cloud that's somewhere in ventricle, and you want to make sure that you're oxygenating the right radial artery adequately and also oxygenating the brain. So almost always we will minimize ECMO flow to that which is required to get adequate perfusion of the brain as well as a radial artery antegrade. Obviously, sometimes you won't get enough, so you have to be on full support. But using the pulsatility of the arterial line and your pulmonary artery catheter, you play a dancing game of withdrawing support over time, and you will gradually be able to, over time, wean support, get more aortic pulsatility, get an advancing cloud that goes further and further down the aorta, which suggests that you can wean the patient off.
Thank you, Venu.